Hello, everybody, and welcome to the latest, the fourth in the series of COVID-19 hosted by the RSM. My name is Andrew Jack from the Financial Times, and today I'm moderating a discussion with Professor Derek Alderson, the President of the Royal College of Surgeons, and Scarlett McNally, a consultant orthopaedic surgeon at Eastbourne at the moment. So welcome both of our participants. We're going to discuss for a few minutes first between ourselves around the trade-offs in a pandemic, and then if the technology is working, at the bottom of your Zoom screens, all attendees should be able to click on the Q&A to pose their own questions for the second half of this session over the next 40 minutes or so. So let's begin perhaps with you, Scarlett. Just tell us a little bit how the situation feels on the ground at the moment as a surgeon. What are you seeing in terms of the effects of COVID on your practice?
Well, there have been huge effects on surgery across all specialties, and it's affecting elective or planned surgery and emergency work in all hospitals in the whole of the UK. There have been some guidance from the Royal College of Surgeons of England, which I'm also a council member, about what operations should be prioritised, but essentially most elective surgery has stopped. Emergency surgery is being prioritised according to clinical need. So some hospitals just have one or two operating theatres running for that. That includes cancer surgery, anything that can waits a bit. And there's a prioritisation system between surgeons about what gets done. We're also seeing fewer patients for emergency surgery. And some of that's quite sad if people are almost scared of coming to hospital, so they need to be encouraged if they've got a problem to turn up to the hospital. But some of it may be that people are actually not suffering certain conditions while there's so much home isolation going on, and that's been noted for strokes and heart attacks and asthma and so forth, as well as surgical conditions. There's also been guidance about what operations should be done. So, for example, the British Orthopaedic Association suggested that fractures that we would normally operate on should perhaps be left, certain fractures, so that we can deal with them in the future if they have a problem. Such as it not being in quite the right place if it's required at that time. So there's a lot more discussion about risks and benefits, essentially.
Derek, what about your perspective? What are you hearing and seeing?
Well, I think that the points that Scarlett made are really opposite. One of the things, of course, that we are seeing is a reduction in the number of patients who are able to undergo very complex surgery. Because of the lack of intensive care beds that are being, of course, quite rightly used in an expanded way for COVID-positive patients. Major surgery involving an intensive care stay exposes patients to considerable risk anyway. So now we have the added problems of bringing them into an environment in which COVID is present, which of course adds to the risk quite enormously. And then you've got the problem of when the patient is recovering from very major surgery, if they have a complication, would you now still have access to intensive care for that patient? So some very major surgery just cannot take place safely at the moment. And the surgeons are having to have conversations with their patients about the balance between proceeding for what is often a very critical and very important condition and the risk, the added risk that that poses to the patient and whether or not the patient is willing to undergo a procedure on that basis. So some very complex cancer operations would fall into that category. And that's really a difficult problem for doctors and for surgeons and the surgical team and everyone involved in the care of that patient to have that conversation with somebody under those circumstances. So that's a real issue.
So Scarlett, let's just talk about those trade-offs. As you say, some understandable and very wise deferring of electives, but have we got the balance right at the moment? Or do you really think now there are some patients who really need surgery who aren't getting it because of the need to clear up capacity for COVID-related cases?
I think at the moment, everyone's done incredibly well in reorganising the whole of the NHS to cope with this pandemic. And surgeons are being redeployed into the COVID positive wards, into critical care environments. Surgeons in training are being moved again into looking after patients. So at the moment, everybody's doing what they can in the crisis situation. The problem will be that when the peak has passed, we can't just deep clean an area and go back to how we were. Some of it's around, the staff will be exhausted for a start, but also there are going to be ongoing risks for patients and indeed for staff. It won't be possible to have COVID-free areas and to only operate in those, for example, because you can't actually tell if a patient has got it or not, or if a staff member has got it or not, they're asymptomatic. So we're going to have to be very careful as we try and get out of this situation and operate on the backlog of patients from not only from the waiting list, but also people whose conditions might have worsened while they're waiting. So that will require quite a lot of extra planning, discussion, to try and get the best for every patient. And it is going to go on for months, unfortunately.
Yes, Derek, I mean, what's your take? There's the pain now in the short term, but then the backlog could take an awful long time to clear, couldn't it?
Yes, absolutely. And I think there's two issues here. As Scarlett rightly says, in the short term, it's very difficult to see how we create COVID-free surgical facilities in many towns and in many cities, particularly when there's only one big hospital for that town or city. Some trusts are fortunate that they possess a number of sites. Their hospitals are on 2 or 3 sites. And there are other examples of where trusts are beginning to work together to perhaps create a COVID-free site. But until we have widespread testing, etc., these things just simply cannot happen. So there's the short-term thing. How do we keep surgery going in the current environment? And the creation of a COVID-free site is something that we would like to be able to offer patients because it would be much safer, but the practicality of it is quite considerable. Then there's the backlog, the fact that we are deferring substantial amounts of surgery, particularly the surgery that doesn't need to be done, let's say, within a week. And remember, we began this year with around 4 million people on waiting lists. And we began this year, or in February at least, with 750,000 people waiting more than 18 weeks for their intervention in our NHS. Whatever else you believe, those numbers are going to rise substantially when we come out of this crisis. And the longer that we are in a kind of restricted ability to deliver surgery, the greater that number is going to be and the bigger the size of the catch-up exercise. As Scarlett rightly points out, I suspect that many of our NH staff will be exhausted after spending months delivering the kind of care that they are currently doing and would quite rightly need a bit of relief before they have to tackle another mountain, the mountain of the number of surgical patients waiting. Bear in mind that with the best will in the world, that's going to be next winter. And we all know what happens to surgical care during the winter months. So we really do need a good, well worked out strategy over a number of years, 5 years probably, a plan with government that addresses this issue and actually brings down the number of people waiting for surgery. You know, we're twice the level we were 10 years ago. That's unacceptable, and it's going to be worse, and we've got to get out of it.
And that's interesting when you say a 5-year plan. So what could that involve? Were you talking about having to recruit more surgeons, thinking about different structural investments?
I think that we will need more surgeons. I think that we do need to reorganize the way in which we deliver surgery in the United Kingdom. You know, there are some great advances that are around the corner. We will see patients in general having the opportunity to be treated at an earlier stage for their illnesses. We will no doubt have some conditions that no longer require surgery, that becomes not essential. We undoubtedly will need to work more as teams within institutions and across institutions. So there is some rationalization of surgical services needed. But at the end of the day, we are short of surgical beds and surgical resources. And there is no way that we can hide from that. So in that 5-year plan, there must be a clear commitment to improving the facilities available to surgeons to a level that seems reasonable with all our predictions about advances that might occur simultaneously.
Scarlett, and I'll come back to you in a minute on Derek's later points there about the longer term, but going back to his earlier question and a question that's come up here already on our live chat. So do you feel also that some HDU and critical care capacity should have been ring-fenced already for non-COVID patients? Wouldn't that have been more ethically equitable?
Things have changed very rapidly over just a few weeks. There are still some, say, cancer patients that are getting operations that really need to be done. And there are some patients who don't have COVID in intensive care and critical care environments. So, as I said, I think everything that needed to be done at this point in hospitals is really being done, and across primary care, across the whole of the NHS. Just coming back to what we need for the future, we need ring-fenced beds in the future. That's been a limiting factor for elective surgery for a number of years. And that's what we're going to need. We need some change to the workforce, particularly so our doctors in training and surgeons in training aren't removed from their critical skill acquiring time in theatre and in the clinics to write administrative tasks. So we need more help for the administrative tasks for doctors. We've got a project of doctor's assistants in my own hospitals, for example. And the other thing that we really need is an awareness of health. There is very good evidence that, say, people who do exercise at the rate of half an hour a day reduce their risk of bowel cancer by 45%. I should have mentioned I'm Deputy Director for the Centre for Perioperative Care, which is an organisation that includes a number of organisations and is hosted by the Royal College of Anaesthetists. And it's about trying to get people fitter and better before their operation. And these things, I think, are going to be incredibly important. People who stop smoking for 4 weeks before an operation reduce their risk of complications by 19%. So we need surgeons to be saying this, we need doctors to be saying this, we need nurses to be saying this, but critically we need family members to say this so that people aren't getting less fit while they're in lockdown, particularly people who are on waiting lists. We want them to come out of this phase fitter and better, and then we might have some opportunities to, say, operate on them in a day case unit rather than requiring critical care afterwards. It really does make a huge difference at just a small amount of interventions. We've got lots of resources on our website, cpoc.org.uk, and there are other organisations. It's around exercise, stopping smoking, and attention to nutrition. But these are people, I think, haven't really realised the critical nature of health, the chance of getting through an operation unscathed, as it were, and also primary prevention, the role of these, what are considered lifestyle things, as absolutely critical in primary prevention of diseases we think of as surgical, as well as many other things.
So I'm going to open it up to more questions in a second, but just a final thing, actually, from a personal perspective for surgeons and operating theatre staff. What are you seeing in terms of actually the direct impact of COVID on your own health and capacity to operate at the moment?
Well, there are a number of NHS staff who are currently home isolating because of a family member with symptoms, and that obviously puts more strain on the everyone who's left behind. There are a number of staff doing very long shifts in PPE, in protective equipment that's it's hard to wear for a number of hours. There are reports nationally of increased likelihood of contracting the disease from people who are exposed over a long length of time to patients with the virus. So, you know, there are problems with, say, the viral dose, so that healthcare workers are more likely to have a problem. And there are patchy issues with supply of PPE across the country. So healthcare workers are understandably very worried, locally and nationally.
Derek, are you worried? Are you hearing a lot of concern about direct exposure of surgeons and operating staff?
Yes. I mean, somewhere around about a third, 40% of surgeons have reported deficiencies in PPE supply during our recent survey. So I think that, you know, one would say that there's no real evidence of that situation deteriorating, but still it remains problematic. And I think that behoves surgeons themselves, of course, to assess the risk that they place themselves under when they have patient encounters where the patient may be COVID positive. And they have to think about what the risk then is that they pose to other patients and to their colleagues. At the moment, it looks like we have about 7% of doctors off work at the moment. They're not obviously all off work because they are proven to be COVID positive, but they are off work usually because they either are or they suspect that they may be infected. I think one of the things that still worries some of the surgeons is the lack of testing within the health service. It really is presently at an inadequate level. The government recognise that and they're doing their best to step that up. But until it is stepped up and is more freely available to NHS staff will find themselves constantly in this dilemma of wondering whether or not they're wearing the right PPE for the right environment, and whether or not they are subjecting themselves to unnecessary risk. So our best advice to people is if there are genuine shortages, you must consider what you believe that risk to be and act appropriately.
So moving over to questions, one that's coming up a lot is around what you're both observing in terms of COVID-19 infections acquired post-operatively, and what's the prognosis in this situation. Scarlett, do you want to go?
I don't have any experience of post-operative COVID-related problems because there's so few operations being done at the moment. There was a very small study from Wuhan in China that where they operated on people that they thought were COVID negative during that phase, and of the ones who were found to be COVID positive afterwards when they had a problem, there was quite a high rate. There was a 40% admission rate to critical care and 20% mortality in those patients having procedures such as cesarean sections and so forth. So it's a small number there. I haven't seen any data from the UK.
Derek?
Yes, as Scarlett says, we only have reports from overseas and we don't have any accurate data for what the relative risk is for the patient who acquires COVID after an operation when they're in hospital. There is a research group led in Birmingham, COVID Surge, that are looking globally at the outcome of surgery in patients who are COVID-19 positive, if they required an emergency procedure, and in patients who acquire COVID-19 in the hospital. They hope that they have sufficient data on a global basis to inform us about what that relative risk is very soon, and we look forward to getting that, but we haven't got data on that yet.
Okay, so another question is about future surgical guidelines in preparation for surgery. What will they be? Derek, do you want to come back first?
Yeah, guidelines in terms of priority of operations, do you mean?
Preparation for surgery, yeah.
Yeah, so at the moment, we realize, of course, that we cannot deliver the full surgical services in the way that we used to before we had COVID. So what we've done is, in conjunction with NHS England and the surgical colleges and the various surgical specialties, is to try and describe a list of prioritization of operations so that patients can be clearly identified by the surgical community, by those who are planning to deliver surgical services in that trust on a daily basis, so that the people who need operation within the first 24 hours are clearly identified. Then there's a group who needs surgery within 72 hours. And then there's a group who can be left for a reasonable length of time, up to, say, a week, and then a month, and beyond that. So we've categorized patients across all specialties to be divided in this way. As a kind of preliminary to that, there are obviously recommendations about the extent to which you should be able to test patients before surgery, to give you an idea, therefore, about what you believe the risk to be, if indeed we accept that there is greater risk for the COVID positive patient undergoing surgery than there is for the COVID negative patient. So obviously, people who require very urgent, immediate surgery, let's say a road traffic accident or any kind of major trauma from a fall, for instance, those patients, there's not time to test them before you need to institute treatment. So that's one kind of group. At the other end of the scale is the person who perhaps needs a cancer operation that ought to take place, let's say, within 3 to 4 weeks. There's every opportunity to test those patients and to try and get them into a protected environment at home where they're likely to remain COVID-free. So there's a kind of series of steps that we've put in place to try and, as it were, deliver the most urgent surgery as efficiently as we can, and to avoid disputes between surgeons and managers, perhaps cases of equal urgency, but if it's in a very specialized area, surgeon A, an orthopedic surgeon, might not understand exactly why something is very critical for a cardiac patient, and vice versa. So we've tried to create a system that itemizes a kind of a sense of priority.
Scarlett, any more thoughts on that, preparations before surgery?
Yes, thank you. We've been doing a lot of work with the Centre for Perioperative Care about how patients can get fitter for their operation. And this has a huge effect in a very short amount of time. And we need the whole multidisciplinary team to work together to give the same messages. So there are messages about fitness for surgery. So exercise for 20, 30 minutes a day makes a huge difference, really huge. Stopping smoking makes a huge difference. Attention to nutrition. So people that can, snack on an apple rather than a sugary snack or high carbohydrates can really make a difference, and weight management for people when they eventually get their operation. And for some of those, it actually avoids the need for an operation in terms of pain management and so forth. So there's quite a lot of things that the public can do and that we can reinforce. Every healthcare professional should be reinforcing to patients about get fitter. In some cases, it might be that if then the person contracts COVID-19, they have a better response to it because they have a better immune system, should we say, from doing exercise and nutrition. So there is that. This is something we need to get our elderly parents to do. We need to find some way that everybody gets this exercise and good nutrition into their lifestyle now, particularly during the lockdown, and we hope it will continue on. The other issue we need to talk about is risk. People have this idea the NHS will look after them and they'll go in and everything will be fine. And even though everyone's trying to do their absolute best now, the mortality rate of this virus is dreadful, and people need to kind of extrapolate so that their everyday lives can be as healthy as possible, so that if they do have a problem, they have the best possible outcome. And people need to know that that's important. And the other thing is how we talk to patients about risks. There's a lot more needed work on shared decision making. 50% of people over 50 have at least one other medical condition, and that goes up and up with every decade, really. So the majority of our patients are elderly and have a number of other conditions. And for each one of those, some lifestyle management could improve that particular condition. So we need to talk about this. And as surgeons, it does seem, I've been a surgeon, 20 years, and it does seem that we almost feel like everyone knows that and we need to get on with the technical bit, which is what we've been trained to do. But we try and have a conversation with patients, but we really all need to try harder to talk about the risks, to talk about optimization, and so that patients can really make their own decision in the presence of all the facts and all the issues and what works for them. You know, for one person, it might be an electric bike. I'm going out on my electric bike every day. For somebody else, they might have to get a static bike for their mother, for example, so that their mother can get the 20, 30 minutes of exercise a day that makes a difference. It's all that sort of thing that we need to think about, and improving people's mental health and what we believe in as health. So there's a lot more about preparing for surgery than or what Derek mentioned about trying to get the systems in place to work. We almost need to reduce the load that's required as well.
Derek, there's a question about how surgeons are coping when they're working outside of their specialty, and actually also when trainee surgeons are potentially having a halt in their learning. What the longer term impact will that have? What's coming, Derek, first?
Yes, so the issue of surgeons working outside their comfort zone or having to learn new skills, this has really been, I suppose, one of the almost triumphs of the current system. Substantial numbers of surgeons have changed their job quite dramatically up and down the country. Many have been taught how to use ventilators and look after patients on a COVID positive ward. Senior surgeons have found themselves or decided that if they can get to the front door of the hospital and work in the emergency department, they can triage the surgical patients much more efficiently. There are many surgeons who are doing lots of telephone consultations or video consultations with patients to try and prevent attendance at the hospital. So lots of surgeons have adopted lots of other tasks. I'm even aware of a cardiac surgeon who has taken up a nursing career in order to help in his hospital because he felt that there was no cardiac surgery for him to do in his area of specialization. So I think that this is a great thing. And of course, this occurs in many other disciplines too. Within the hospital, people have learned to adapt. And I think it's one of the great testimonies to our overall medical workforce that people have been willing to do this and shown the ability to do it. and that with support from our anaesthetic and intensive care colleagues who've taught people how to use ventilators very quickly, that we've actually come to a safe system. As far as the surgical trainees go, then of course this is a major, major problem, especially in surgery, where people have to demonstrate their competence with individual surgical procedures and their ability to deal with certain conditions and situations that allow them, in our system anyway, to become to receive a certificate of completion of training and to become eligible to be a consultant in our National Health Service. And the fact is, if you're not doing that type of surgery anymore, it's difficult for people to prove that they have achieved those competencies. We also have the problem of not being able to conduct surgical examinations that form part of people's training to allow them to progress in their training. So this is having a really important effect on our trainees, who, of course, we are doing our very best to reassure that we will see them through this without detriment. And certainly our pledge to every surgical trainee is that no individual should have their career prospects irreparably damaged as a result of the way in which they are being asked to function during this crisis. Health education have put some steps in place to try and allow people to make progress so that new people can enter the training system this summer. And, you know, what can one say? We are trying to make the best of a bad job, but there we are. So trainees are quite rightly very anxious about it. We're working very closely with training organisations to support them and help them. But I do feel for trainees in surgery at the moment because of what's happened.
Scarlett, are you worried about those trade-offs between surgical specialisms and also this backlog, as we're saying, around trainees?
Yes, I think that the trainees are working incredibly hard, but they're not increasing their surgical skills capability at this time. What I'm really hoping is that will be a big focus on training once we can to improve that. There have been a lot of advances in medical education over this time as well. So some things are being made available electronically that never were before. There's also more breaking down of barriers so that we understand how other specialties work. So I'm hoping that the skills training can be kind of caught up with in the future, but people are doing amazing work in terms of their interpersonal skills training, risk discussion with patients, understanding physiology around surgery. There's all that sort of thing that is beneficial for some doctors in training at different levels, as well as just the technical side.
And there's actually a question goes back to Derek's earlier point about the need to hire more surgeons longer term, but given the shortage globally, how will that be feasible?
Well, it takes several years to train a surgeon. My thought is we need to maximize the productivity, shall we say, of the people who we already have. And at the moment, we had a report from the Royal College of Surgeons a couple of years ago showing that 50% of the doctors in training time was spent doing administrative and other tasks of low educational value. So there might be an easy win there to get surgeons in training more into the operating theatre and into the clinic to use their skills and to learn where they want to learn. And in terms of the consultants and SAS surgeons who are trained, we need beds so that patients are ready, available to operate on. We need the facilities so they aren't, I'm not going to say wasting their time, but so there isn't of their productive time, they can achieve more operations, should we say, in the time that they're there. And that's a big problem. The lack of beds is a big problem. So it's not in terms of recruiting doctors from somewhere else or trying to train people very quickly. It's, I would say, using the people that we have and maybe training others to help. As I said, we had a very successful pilot of the doctor's assistant program, so that there's someone when a doctor wants to do something, there's someone else that they can delegate the task that it's possible to delegate to, and they can concentrate on doing what they're really, really good at and on their education.
Derek.
Yeah, I agree with everything that Scarlett says. I mean, we do need a bit of a recruitment drive. Surgery is a very popular subject. If you ask medical students, what would you like to be? Large numbers of medical students say that they'd like to be surgeons, but we feature relatively in a small way in curricula nowadays. So we obviously do need to do things that show people just what the variety of surgery really is. So there's an element of that. In terms of numbers, though, if we can get more people into surgery, that will help. We have to have more diversity. You know, there are lots of technical procedures that can be trained. People can be taught how to do them. You don't have to be a fully qualified surgeon to do that. And I think that this idea that we'll work in bigger multi-professional teams has to be the way to go in order to give patients the best treatment they can. And then there is this issue, as you rightly point out, of how do we ethically, as it were, become more of a global surgical community. We can't simply raid other countries for surgeons. That's clearly not the right answer. But there might be ways in which we can work more collaboratively with other countries in order to deliver better quality surgical care on a global scale that actually benefits trainees in the United Kingdom as well.
So Scarlett, there was a question as well on the cooperation between the NHS and private healthcare providers, how far that's happened so far, and are there any risks of, as the questioner puts it, cross-contamination between patients in private and NHS care?
Thank you. Some of the private sector has been incredibly helpful in donating equipment and also allowing all their services to be used for NHS patients. In my own trust, we're going to try and start doing our trauma operating in the local private hospital. Obviously, there are difficulties working somewhere new, and that's required the management to do a huge amount of work trying to get this in place. In terms of cross-contamination, at the moment, this is being done as trying to create volume in the capacity. We're almost at the stage you have to assume that everyone might have COVID-19 rather than assume you can have a clean facility and a dirty facility, because with a lengthy period that people might be asymptomatic and with staff who are exposed to it on a daily basis and then come back to work, you can't really have a COVID negative facility. So I think private providers are being really helpful, but I think everyone realizes this isn't going to be clean versus dirty. It's just another layer of help.
So we're running up almost out of time, but Derek, briefly, there's a question here about patients and how to cope when they want to go ahead and they're struggling to obviously be considered a priority. What are those? They're not considered priority at the moment. How are those discussions rolling out, and what's the sense of patients?
That's an excellent question. These are really difficult consultations. As Scarlett said, the issue nowadays is to talk to patients about what we call shared decision making. It's not simply about the surgeon telling the patient that we think X is what you ought to have, and the patient says, okay, I'll have X. I think that there's a lot more to it now, and consultations definitely have become much more difficult. It's easy enough to have a consultation with a patient about a condition that you think is extremely unlikely to deteriorate significantly over a month or two. And most patients are fully in agreement when you suggest deferral to them, because they know that they're benefiting other people and that they're not likely to deteriorate. I think it's much more difficult when you talk about time-dependent operations, things where the clinician knows that the condition will inexorably deteriorate over a matter of weeks, and where the possibility of severe harm or even death might then rear its head. Those are really difficult consultations. I think that we're doing our very best, but the problem that everyone still faces is trying to give patients good factual information about what the two sides of the coin might be. The risk of the condition versus the risk of what might happen if you become COVID positive if you go ahead. And we just do not have high quality information and data on which to advise patients. So there's the dilemma. And I think that it is a really difficult thing, and it's likely to persist for a while yet.
Scarlett, a final word maybe on that to wrap up?
Thank you. Yes, it comes down to a balance of risks with every patient, as it always has, really. The nice thing about lifestyle modifications is for some patients, it's something they feel they can be doing while they're waiting, or they can help their family member with. So if any good comes out of that, maybe that's it.
Okay, well, I'm sorry to say that we've run out of time. Thank you both for your great contributions, and thank you all to everyone who's been plugging in to ask. Apologies we couldn't get through all the questions, but thank you all for all your great efforts at this very difficult time. I think the point very well made from Scarlett about prevention and exercise, and from Derek and from Scarlett about really the challenges, not only in the short term and the risks to surgeons and patients and other staff, but also, of course, longer term, how we cope with the backlog and the reprioritization for many months to come. But thank you all for taking part again. I believe those viewing will get an automatic follow-up, so we urge you to fill that out for feedback. And thanks very much for watching.
Thank you, Andrew. Thank you.
Thank you.